working as a nursing officer in research department of Ministry of Ayush, Government of India Regional Ayurveda Research Institute, Lucknow. So he did his certificate course in Essentials of Palliative Medicine, Palliative Care from Indian Association of Palliative Care, and he is one of the mentor of Fellowship in Palliative Care program. This is done by St. Christopher Hospice in collaboration with the Institute of Palliative Medicine, Calicut. He has a lot of publications, and uh, due to some network issues, he could not able to join through online, but he had sent his recorded version of the wound management session. So we are planning to play that recorded session now. So most probably he will join soon for the question answer session. So over to you, Sonia. Please play that session.
Welcome to the foundation course in palliative nursing. I'm Sachin Dwivedi. Today I'm going to take
Sister Shiba, visible and audible?
Yes, it's visible.
Okay, so that we can continue.
lecture on pressure sore that comes under the wound management. So in today's lecture, we are going to discuss about the pressure sore. What is the definition of pressure sore? What are the types of pressure sores? What are the different risk factors that may lead to the pressure ulcer or pressure sore? What are the sign and symptom of pressure sore? And what are the various stages in pressure sore? How we can assess if anyone having pressure ulcer or pressure sore? What is the management of pressure sore? What are the complications that patient may have if the patient have pressure ulcer? And what are the preventive measures that need to be taken to reduce the risk of developing the pressure ulcer? So we'll discuss one by one. We all know that pressure injuries or decubitus ulcer or pressure ulcer continue to plague patients and the healthcare community. Despite advances in medicines, the incidence of pressure injuries has remained stable and even slightly increased over more recent years, according to some existing literature. Various studies have attempted to quantify the problem. A meta-analysis by Lee et al. Suggested that the global prevalence of pressure ulcers to be 12.8%, with a hospital-acquired pressure injuries incidence of 8.4. So this is a very high number that pressure ulcer is affecting our patients. About the pressure sore, what is the definition? So pressure sores are also known as pressure ulcer or bed sores. The name itself, it representing that there is something pressure that ultimately affect the skin. So these injuries to the skin and underlying tissues primarily caused by prolonged pressure on the skin. If any patient is continuously bedridden for longer time, the person or patients may develop pressure ulcer. They can happen to anyone, but usually affect people confined to bed or who sit in chair or wheelchair for a longer period of time. So especially terminally ill patients, critically ill patients, or patient those who are uh, with life-limiting disease or in home but unable to uh, come out with the bed by self or confined in the bed or wheelchair, they are more prone to develop the pressure ulcer or pressure sore. Then we'll move to the types of pressure ulcer. We all know that as a healthcare professionals, we have to very vigilant about different types of pressure ulcer because, for example, if we are working in any institutions, so any patients came to the hospital with some pressure ulcer, so we need to understand that whether the patient already have developed the pressure ulcer or patients develop pressure ulcer after getting admission in the hospitals. So proper assessment of pressure ulcer or pressure sore is very important so that we should know about what are the types of pressure ulcer. So first one is the community acquired pressure ulcer, that is CAPU. So the name itself, the pressure ulcers that develop prior to the hospital admissions. The existence of pressure ulcer was documented on the admission skin assessment or the survey was done on day first of the patient's hospital stay and the pressure ulcer was already present. So as a healthcare professional, we should check, we should record whether patient is already having pressure ulcer and which stage it is. The pressure ulcers that present on admission worsen during the patient length of stay are still considered community acquired. So sometimes it's safeguarding us also for proper assessment of pressure ulcer because sometimes the caregivers, family members, they blame us that the pressure ulcer is developed due to the hospital stay. So we need to very vigilant. Then second one is the hospital acquired pressure ulcer, HAPU, HAPU. So this hospital acquired pressure ulcers refers to new pressure ulcer developed after admission to a healthcare facility. Sometimes it is also termed nosocomial or facility acquired pressure ulcer. So the patient admission record should be reviewed for the documentation of pressure ulcer. If there is no documentation that the pressure ulcer was present on admission, then the pressure ulcer should be counted as a hospital acquired pressure ulcer. The risk factors are mainly two types, direct risk factors and those who affect indirectly. So the first one is the pressure. So the pressure usually develops when a client is bedridden or in the wheelchair for the prolonged time without changing the position. So it start affecting the blood supply to that particular region, especially the bony prominences area, and start damaging the skin or tissues. So we should avoid the pressure that will help to prevent the bed shoot. The second one is the shear. Shear will develop when we move the patient from the bed. For example, bed is the fixed object or wheelchair. So we have to be very careful during moving. Okay. So it will develop the shear when we'll move body from any fixed object. So the next one is the friction. So this friction is mainly rubbing the one surface to another surface. The body surface is rubbed in the bed or in the bed sheets or in the any surfaces. So that may lead to friction or that may damage the superficial layer of skin that ultimately lead to pressure ulcer. Then immobility. This immobility may be due to any disease condition or may be due to the aging. The person is not able to move from his or her place or his or her condition. So these type of patient having more chances to develop the pressure ulcer. Then loss of sensation. So the condition that may affect mainly the patient with paraplegia or paralysis or patient with some vascular condition, those who lost the sensation mainly in the extremities or sometime in the whole body. So they are not able to move, also not able to change the position also. So loss of sensation is also lead to pressure ulcer. So we need to very vigilant about these risk factors. Then come to the indirect risk factors. So first one is the mobility problem. Okay. So any person with any mobility problem, like the person with surgery, okay, so any person with any surgery of orthopedics, related to orthopedics, or surgery related to cardiac, so these type of patients need to be limited the mobility, or sometime they have some pathological issues that affect the mobility, that ultimately patient is lying on the bed or wheelchair for the prolonged time, and they are prone to develop the pressure ulcer. Then nutrition, poor nutrition. So nutrition is very essential part of our body, and especially for those who are not able to move or completely bedridden. So these patients are given preferences to provide good nutrition. So poor nutrition or poor hydration ultimately affect the skin condition, and it may lead to dryness of skin and erosion of skin that ultimately lead to pressure ulcer. Then health problem. For example, any patient already developed any chronic condition like congestive heart failure, or any cardiac surgery, or any type of chronic disease, that patient is not able to move from his or her place. Okay, so sometime due to these health conditions, patient is confined in the bed or chair, that also lead to the pressure ulcer. Then aging, we all know this is the very common cause or risk factor for the pressure ulcer. So due to the aging, the function of body is going to diminish, all the body function is going to diminish, and the patient is not able to move from his or her condition. Patient is confined in the bed, patient is not able to maintain the activity of daily living. So the aging is also one of the risk factor. And the incontinence, due to the aging, due to the pathological condition also, if the patient is bedridden for the prolonged time, and patient is having no control on bowel and bladder movement, so ultimately it lead to moisture, and the moisture is one of the factor that may lead to the pressure ulcer. So we need to very vigilant about direct and indirect risk factors when we are working with our patients in hospital or out the hospital settings. Then common sites of pressure ulcers. So any patient, those who are sitting in wheelchair, those who are utilizing wheelchair for the prolonged time, the patient may have risk to develop the pressure ulcers mainly on buttocks or tailbone, and shoulders, blade and spine, and sometime back of arms, legs, where the rest against the chair. So when they have any support in the surface, and the body weight is bared by that particular surface, so they have more chance to develop the pressure ulcer if they are in same position for the longer time. So these are the common site of pressure ulcer, those who are using wheelchair. Then we'll move to the patient, those who are confined in the bed for the longer period of time. So these type of patient mainly develop the pressure ulcer on the back or side of the head, the shoulder blades, the hip, lower back or tailbone, the heels, ankles, and skin behind the knees. So these are the common area that patient develop the pressure ulcer, and during the assessment we have to be very careful to inspect all these areas. Then the warning sign of pressure ulcer. Pressure ulcers having different stages. So the manifestations, the symptoms are changing in stage by stage, but some are the warning sign that will help us to understand that patient is going to develop the pressure ulcer. So we as a healthcare professionals, We'll be very careful, very vigilant, and we have to periodically assess our patients or our client for preventing the pressure ulcer. The first one is the unusual change in skin color or texture. So during the assessment, if there is any change in the skin color, so mainly we have to assess that whether it is pressure ulcer going to develop in that particular area, whether patient is confined in the bed for the longer time, whether patient is confined in the wheelchair for the longer time. So all these are the factors that may uh, usually change the skin color for the patient, this type of patient. Then swelling. So is there any swelling in skin area that ultimately be a sign of pressure ulcer? So maybe there is a interruption of blood supply, and there is change in the demand of that particular tissues at that affected area. So there is swelling in the affected site. Sometimes it may show pus-like drainage when the tissues become damaged, and it may show some pus-like drainage at that particular area is also a warning sign of pressure ulcer. Then an area of skin that feels cooler or warmer to touch than other area. So if the surface that is affected with the pressure ulcer, if it is cooler or warmer with the other areas, the other normal area surface, that we can say that the patient having risk of pressure ulcer. And the tender areas, when we touching that particular surface, if patient feel or complain about pain, that means the patient having a risk of pressure ulcer, or this is one of the warning sign of pressure ulcer. Then we'll move to the stages. In pressure ulcers, we have four stages: stage 1, stage 2, stage 3, and stage 4. So as per the area of involvement, the stages are divided. Okay, so for example, in stage 1st, the mainly area that is affected, that is the epidermis area or superficial area, and it shows, you can see in the picture, it shows the light pigmentations or skin color is changed. Sometimes the area looks like red and feel warm to touch. With darker skin, the area may have a blue or purple tint. Okay. So the person may also complain that it burn, hurts, or itch. So we have to be very careful to understand, and will listen the patients also. We ask for any tenderness or any pain at that particular pressure injury site. Then move to the stage 2. So in the stage 2 pressure ulcer, you can see that the epidermis and dermis is involved mainly. So here two most important layer of the skin is involved, and this area looks more damaged and may have open sores, scrap, or blisters. The client complain of significant pain, and skin around the wound may be discolored. Then this is the second stage of pressure ulcer. Then we'll move to the third stage of pressure ulcer. In the third stage of pressure ulcer, the third layer of skin, that is the subcutaneous area, subcutaneous tissues are involved. So here epidermis, dermis, and subcutaneous is involved, that is divided in stage 3, and the area has a crater-like appearance due to damage below the skin surface. Then we'll move to the stage 4. The stage 4, the area is severely damaged and a large wound is present. So earlier, all the three layers have involved, but in this, the muscles and tendons is also involved, and uh, the bones is also involved. So these area, these this stage is very harmful, and sometime it may lead to infection to the bone also, and develop some bone and joint infection like osteomyelitis. Okay, so stage 4 is very difficult to manage, so we have to very careful, we have to assess the patient periodically and try to find out if there is any suspicion to develop the pressure ulcer in the early stage. Then the assessment of this pressure ulcer. So for predicting the pressure sore risk, there is one scale that is known as the Braden scale. So in the hospital settings, we are mainly assessing the risk of pressure sore, and on the basis of risk, we are planning some intervention for our patients. So here there is category 6 element that we have to keep in mind, and on the basis of the patient's activity and patient responses, we have to give some numbers, and we have to uh, calculate the total score, and on the basis of a score we can say that our patient is on risk or the patient needs some preventive intervention and patient is not in any risk. So for example, under the sensory perception, okay, so sensory perception means patient's ability to respond meaningfully to any discomfort or pressure related discomfort. So when patient is unresponsive, maybe due to painful stimuli, due to diminished level of consciousness or sedation. So here is limited ability to feel pain over the body. So we can give one score. Then if patients have very limited respond only to painful stimuli, we can give 2 score. When the patient have slightly limited on sensory perception means respond to verbal commands but cannot always communicate discomfort, we can give 3 score. And if there is no impairment, patient respond properly with verbal command and there has no sensory deficit, we can give 4 score. Then the second one is the moisture. So moisture is one of the factor that may lead to the pressure sore. So degree to which skin is exposed to moisture. So we have to very vigilant. The first score is constantly moist. So skin is kept moist almost constantly by perspiration, urine. Dampness is detected every time patient is moved or turned. So mainly in the incontinence patients also. Then we can give 1 score. Very moist skin is often but not always moist. So we can give 2 score. Occasionally moist skin is occasionally moist require an extra lenient change approximately once a day. So we can give 3 score. And rarely moist the skin is usually dry, so we can give the 4 score. Then we'll come to the activity, the degree of physical activity patient is performing. If the patient is confined to bed, we can give 1 score. When patient is ability to walk severely limited or non-existent, cannot bear own weight, must be assisted in chair or wheelchair. So we can give 2 marks and we can say that the patient has chair fast. Then the walk occasionally during day but for very short distance. So we can give 3 score. Then walk frequently, there is no impairment. So we can give 4 score. Then mobility. It is the ability to change and control body position. So sometime due to any underlying conditions, patient is completely immobile. So we can give 1 score. Very limited, occasionally slight changes in body or extremities position, but unable to make frequent or significant changes. So we can give 2 score. Slightly limited makes frequent through slight changes in body or extremities position, that is give 3 score. And if there is no limitation, makes major and frequent changes in position without assistance, we can give 4 score. Then come to the important aspect, that is the nutrition. So usually food intake pattern we can assess in the nutrition. So if the patient is never eat a complete meal, rarely eat more than half or any food offered, eat 2 servings or less of protein. So or sometime NPO. So patient given 1 score or very poor nutrition. Then rarely eats complete meal, and generally eats only half of the food offered, and receive less optimum amount of liquid diet or tube feeding. So this is probably inadequate and we can give 2 score. Then eat over half of the most meals, eats a total 4 serving of protein, is on tube feeding or TPN regimen, which probably meets most of the nutritional needs, so we can give 3 score. And if the patient eats most of the every meal, never refuses a meal, usually it's total 4 or more servings of meal, so we can give 4 score or excellent. Then come to the friction and shear. So require moderate to maximum assistance in moving, or complete lifting without sliding against sheet is impossible. So frequent sliding down in bed or chair require frequent repositioning with maximum assistance. So any patient having this problem, we can give 1 score. Patient moves feebly or require minimum assistance, we can give 2 score, or patient have potential problem. And we can give 3 score if patient have no apparent problem, moves in bed and chair independently, and has sufficient muscle strength to lift up. So this is the Braden scale, and these are the parameters we have to assess. And on the basis of patient condition, we have to give some score, and these scores should be counted at the end. And on the basis of the criteria of scoring, we can say that our patient is not on risk if the score is between 19 to 23. If it is between 15 to 18, we can plan some preventive interventions. If the patient having 13 to 14, a score that patient having in moderate risk. If it is 10 to 12, the patient is on high risk. If it is 6 to 9, the patient is on very high risk to developing the pressure ulcer. So we have to be very careful during the assessment and during planning intervention for our patients. I have taken one case study. For example, Mr. P, those who got fractured left hip with total hip replacements, lives alone. Incision dry, intact, but no sign of infection, and age well approximated. Skin assessment on admission and in 24 hours. So there is no special attention to heel and sacrum, no reddened area noted. Patient have cognitively alert, and the pain level is 8 by 10. The sensitive perception subscale. Perspiring heavily, no evidence of incontinence or wound drainage. The moisture subscale. Out of bed with assistance and wheel walker patient 5 times per week. Toe touch weight bearing left leg. Comes under the activity subscale, mobility subscale, friction and shear subscale. Eating habits at home: banana, coffee or breakfast, cereals for lunch, canned soup and cookies for dinner. The patient BMI is 23.5 and states he has little appetite and often eats only if he feels like it. Does not take any dietary supplement. So on the basis of Braden score, so we have given the 4 score for sensory perceptions. For the moisture, because of the perspiration, we have given 3. For the activity, we have given 3 because of immobility due to the disease condition. The mobility also we have given 2. For the nutrition, he is not able, he is very not taking the meal frequently and only feel hungry, only take the meal. So we have given 1. Friction and shear we have given 2. So total prevent 15 scoring we have given. So on the basis of the criteria, the patient needs some preventive intervention. Otherwise, patient develop the pressure ulcer very soon. So this is the Braden score to, total for the patient's P. Then in the assessment, what are the things we need to be very careful? So in the clinical assessment, we should include, first one is the history of ulcer, including the cause, any factors like patient is immobile for a longer period of time due to aging, due to illness, due to underlying condition. Okay, so what is the duration, or is there any previous treatment he or she got? Then come to the anatomical location, whether patients develop the ulcer we have to check a different anatomical location in the heel area, also in the buttock area, also in the arm area, also in the head also. So anatomical locations assessment is very important. Then we have to see whether patient is in which stage, or what is the size of that particular pressure ulcer or pressure sore. And uh, in the size, we have to specify the length, width, and depth in centimeter. So it will help to assess the outcome of any intervention when we plan. And is there any sinus tract underlying or tunneling or dryness? So this is mainly in the later stage or pressure ulcer. So we have to be very careful. We have to assess for any drainage or tunneling. Then, is there any necrotic tissue or slug or scar is present? So, the slug is mainly in yellowish in color. So, if there is any slug or a necrotic tissue is there, so we have to be very careful. We have to differentiate that the patient having which stage of pressure ulcer. Then, granulation tissue, sometimes newly formed tissue within a healing wound. So we have to assess whether the uh, injury or ulcer may have some granulation tissue for the recovery of that particular uh, condition. Then epithelialization, regenerated tissue within a healing wound. So we have to assess all the aspects, whether the patient is recovering, whether the patient uh, the in which stage, and on the basis of stages, what are the interventions we can plan for our patients. So assessment is very important aspect of pressure ulcer management. Then we'll move to the management. So the management is depends on the patient's stage, but some of the common measures I have mentioned here. So first one is removing pressure on the affected area. So how we can remove the pressure? By providing the air mattress or water mattress. Then air and water mattress ultimately remove the pressure in the affected area. Then we can protect the wound with medicated gauze or other special dressings. So mainly these dressings are available in markets, and they have in different sizes. So on the basis of patient's wound, we can choose the site, because earlier in the assessment we have recorded the uh, depth, length, and width of that particular foot. So these are the special dressing available in the market that will help. Like in the picture, it shows the size of this dressing is mainly for the sacral area. So it is very easy to apply, and it is to relief from pain, and it is to healing the pressure ulcer. Then keeping the wound clean. So cleaning is very important. So always try to focus on the cleaning and use some sterile equipments during the cleaning, and periodic cleaning will help to remove the debris or remove the risk of infection at particular affected site. Then ensure good nutrition. So we have to be very careful, because nutrition is one of the factor that may be increase the risk of pressure ulcer. So we have to maintain good nutrition by providing the protein rich diet, and we have to hydrate our patients. We have to provide the if the patient is on tube feeding, so we have to provide tube feeding at particular interval. We have to calculate the requirement of our patient, calorie requirement of the patient with the help of our dietitians. So we have to provide nutritional support to the patients, and that will help to manage, or that will help to prevent the risk of pressure ulcer. Then removing the damaged or infected or dead tissue. So debridement is the process when we remove the dead tissues from affected area. So we have to be very careful through the sterile technique, we have to debride the particular uh, dead tissues, and that will ease of healing. Then the transplanting healthy skin to the wound area, that is a skin grafting. So if the area is taking too much time to heal, and all that dead tissues are removed from that particular area, so we can also choose the grafting at that particular site, and it will be heal soon. Then negative pressure wound therapy. So negative pressure wound therapy mainly apply the patient, those who are having the collection of fluid or pus at the wound site. So these type of therapy mainly we require some special instrument that may generate the negative pressure, and these instruments suck the that discharge from that particular area, that help to reduce the healing, that is in healing. Then sometimes the patient needs medicines to treat the infection. Sometimes it may develop some growth, bacterial growth over the affected area. So sometimes he or she needs antibiotics to treat the infection. Then what are the complications? So usually the patients with pressure ulcer, if it is untreated for the prolonged time, sometimes develop the cellulitis. Then very commonly when the patients on the fourth stage of pressure ulcer or third stage of pressure ulcer is untreated or not getting any proper care, that may lead to the infection to the bone, that is the osteomyelitis, and it is very dangerous. Sometimes patients uh, undergo for the amputation due to the poor healing bone infection, that is osteomyelitis, and it also affects the joint also. Then sometime it may lead to cancer. So long-term non-healing wounds is a type of lead to a type of ulcer, that is Marjolins ulcers can develop into a type of squamous cell carcinoma. So sometimes it may be complicated if it is untreated. So we have to be very careful and very vigilant. And the sepsis, because our skin is the protective barrier for the infection. So if there is any breakdown in the skin, ultimately patient is on risk to develop the sepsis. So we have to be very careful, follow the principle of aseptic techniques during the cleaning, washing, and during all the care given to the patients. Then the prevention aspect. So mainly we have to turn our patient or reposition our patient every 2 quarterly, or we can also for the patient those who are immobile for the longer period of time or have some mobility problem, we can give some range of motion exercises, active and passive range of motion exercises. Then sitting upright and straight in a wheelchair or changing position every 15 minutes. So we have to change the position if the patient is on wheelchair or in the bed. So periodically we can plan accordingly. And we can provide some soft padding or cushions under the wheelchair or under the bed, or we can take the help of pillows. So these things will help to reduce the pressure ulcer. And about that, we can provide good skin care by keeping the skin clean and dry. So here we have to be more vigilant about to prevent from moisture, and we have to keep our skin dry. If the patient having any incontinence issue, we have to check the linen, and we have to change it timely. Providing good nutrition, because without enough calories, vitamins, minerals, fluids, and proteins, bed sores cannot heal, no matter how well you care for the sores. At the last, bed sores are ulcers that happen on area of skin that are under pressure from lying in bed, sitting in wheelchair, and or wearing a cast for prolonged period. Bed sore can happen when a person is bedridden, unconscious, unable to sense pain, or immobile. It can be prevented by inspecting the skin for areas or redness, the first sign of skin breakdown, every day with particular attention to bony areas. And for the family and caregivers, we can educate, aware them about how they can assess at home. What are the common things they can do, like changing the position periodically, focus on the nutrition, changing the linen if it is moist. So, active and passive range of motion exercises. So, these are the small things that we will educate to our clients, family members, and caregivers to prevent these type of pressure sores and pressure ulcers. Thank you so much. For any query, you can mail me on my email ID sachindwivedikgmc@gmail.com or contact me for my contact number.
Thank you, Celia, for playing this recorded session. Anybody have any doubts on pressure sore management, please? Uh, anything you want to discuss, please? I understand this is one of the common nursing issues in everywhere. Settings also, you will get more patients with pressure ulcer. So you will have a lot of questions. Please ask if you have any questions. So I would like to see you all. Please switch on your video, please. You. The wonderful smiling faces, but you always switch off your video mode, your video, so that we are not able to see you. No. So okay, so we had a good session now. So if you have any questions regarding this pressure ulcer things, please ask. Anybody?
Mehboob ma'am, if you want to,
Ma'am. Any question, ma'am?
You are muted.
Ma'am, any questions?
Yes, ma'am.
Video has some problem.
Like, I would like to ask you, ma'am,
Ah.
like, the gauze pieces which we are using, that itself is causing little bit of irritation to the wound. Yeah.
Which one, ma'am? Which one?
Like the gauze pieces which we are using ideally is itself is causing some irritation to the wound. Like, why don't we switch on to some softer thing, like maybe that banana peel and everything is now used in burns cases. So like that things can be used in the bed sore to heal more comfortably, like.
You are correct. The thing is, there are lot of the practices is there, but we don't have any evidence. So that is why we usually don't tell these. It's the good way to manage these things. These type of work.
Like, ma'am,
Yeah.
I'm working in Scion Hospital, LTMG, Mumbai. It's a very big hospital in Mumbai. Like, BMC hospital it is. Like Dr. Gore, who is burns specialized doctor, who is using this banana peel, banana leaves.
Okay. So, so most of the places and I know more, some of the doctors, they're using the banana leaves, but I don't have any personal experience. That is why I don't have any evidence to do this kind of practice to tell you. If you have some experience, definitely the others can also, if they are willing to try it, the others can also try it.
Like, maybe Dr. Gore has his burns, they have conferences and seminars all on burns management. They in fact emphasized on this type of dressing to use, because it reduces the loss of blood and serum and all, and plus it gives cooling effect to the wound side, and less of pain while removing the dressing. And with the minimum this one, dressing material, we can manage the bed sore points, sides.
So it might be there. So
Thank you, ma'am.
Ma'am, there is a question in the chat box, like any
might
other.
have good things will be there. So if you can you hear me?
Yes,
Yes,
ma'am.
yes,
Please.
Yeah. So you, as I already mentioned, you have some this kind of wonder.
Sister Sheba. Ma'am, we can hear you.
You can also continue for the same. Here, I would like to highlight few things on. Yes.
Ma'am, you are not audible.
What about now?
Now you are audible. You weren't audible, and then.
Oh, okay. So thank
the
you.
answer
Sorry.
wasn't clear.
Yeah. So regarding the pressure sore management, I would like to highlight.
Hello. Sheba, ma'am. Hello. Ma'am, can you hear me?
Yes.
Hello.
I hope my audio is clear now.
Ma'am, you weren't audible then also. We couldn't hear
Now,
anything.
so what about now?
Now you are audible, but when you start speaking, there's no sound coming up.
Okay, so let's see. So sorry for that. Anyway, the pressure sore the management is very important in palliative care, but in everywhere. So if a bedbound patient there, they might have a chance to develop pressure ulcer. So we are the person to teach the caregivers and the patient about how to prevent pressure ulcer. And if it is there already there, we have to educate them how to prevent, prevent the next one. So these are the important things. Without caregiver support, we can't do anything. So we need a caregiver support. So we need to empower the caregivers for preventing pressure ulcer. So for preventing pressure ulcer, you have to keep it in mind. SKIN, skin, SKIN. The first S is supporting surface. If you have seen a patient, bedbound patients, you have to think about whether the patient is having a proper supporting surface, like airbed or water mattress, or extra pillows, whatever it is. You have to think about that. And the second is skin inspection. So we have to change. We have to be when change the position every 2 to 3 hours, every second only, at least. So that time you have to look at the major pressure points. Okay, if you have seen, if you have noticed any color change in that area, you have to prevent further the prevention on that area. So that is the management of stage 1 pressure ulcer. And the third one is K. K is keep moving. So every 2 to 3 hours we need to change. We need to change the position. Keep moving. And the next letter is I. I is incontinence. So if there is we already understand that moisture is one of the major cause of pressure ulcer. If there is incontinence there, what happens? Again, the patients will get moisture and can cause pressure ulcer, no? So we have to prevent that. If they have an incontinence there, we can try to put a catheter. If they are not willing to put a catheter, what way we can manage? You can manage with a diaper, or you can ask them to use. They are not affordable. They can use their own clothes. But the thing is, if the linen's wet, they have to change it as soon as possible. That is the way they can manage for the incontinence. And the last letter is N, nutrition and hydration. So this is very, very important. Without nutrition, the lack of nutrition, the protein intake in their diet can cause pressure ulcer. So these are the major points you have to keep it in mind whenever you have seen a bed-bound patient. The first S is supporting surface. The second S is skin inspection. The third letter is K, keep moving. Next one is I, incontinence control. And the next letter is N. N is nutrition and hydration. So these are the important things you have to keep it in mind. And the another thing is management. So the first stage is non-branchable erythema. That time you can manage with you can prevent further pressure on that area. That is the management of stage 1. The stage 2 is again that area is the skin is damaged. The dermis layer will be damaged, loss of dermis layer. So, but the thing is, only the layers will damage. There is no pus formation or infection will be there. So that time you can clean with normal saline. That is the management of stage 2. If there is a stage 3 pressure ulcer and 4 pressure ulcer based on the skin, the wound condition, like if there is a necrotic issue there, you have to you can remove the slump from the wound. So the slump cutting is possible. And the another thing is you can use metronidazole powder for preventing if there is a malodor anaerobic bacterial infection there, you can use metronidazole tablet. You can take tablet and crush it, make the powder form, and you can apply that powder, that metronidazole powder on the wound. So better you can mix with the white petroleum jelly, so that the wound will get two effect. The white petroleum jelly will give the moisturizing effect, and the metronidazole will reduce the infection. Okay. So, and you can use charcoal also. Charcoal is one of the best agent for controlling the absorbing bad smell. So you can use charcoal dressings, and you can, if the dressings are not affordable, the charcoal dressings are too expensive. If they are affordable, you can suggest. But if they are not affordable, then you can use charcoal pieces. So that will one of the you can take 1 or 2 pieces charcoal and keep it under the patient's bed, or keep it in the corner of the room, so that will absorb the bad smell. So this way. And another thing is that you can use air mattress, water mattress. This way we can manage. And the last stage 4th pressure ulcer usually if the patient's health condition is okay, then you can think about the surgery, skin grafting procedure. You can refer the patient to the surgeon and think about whether the patient, skin grafting procedure is possible or not. So that is the management of stage 4 pressure ulcer. But if the health condition is not good, then you can do only for pain management and cleaning and dressings. That is enough. But the patient's health status is good, then you can think about the curative management, like skin grafting procedure and scalp cutting. These all things you can think. And the another thing is make sure that before doing the dressing, you have to make sure that the patients will be pain-free. If the patient is having pain, you have to give some analgesics and make sure that whether the patient is not having any pain, then only you can do the wound management part. Okay, so this is very, very important. When we do the assessment on wound, you have to ask them whether they have pain or not. If they have pain, you can give some analgesics on that. Okay. And so I think we have a small video on prevention of pressure ulcer. Senior will show you now. After that, we will have a patient story presentation. The story will be presented by Sister Rita. Senior, please show that video.
Bed sores are easier to prevent than to treat. Mr.
So I think so it is clear to everyone how to prevent pressure ulcer. I think we can move on to the patient story presentation. Sister Rita, are you there? So over to you.
Sister Rita.
Sister Rita, can you hear? Yeah, you can unmute yourself and talk.
Rita.